Now, sure, we've thrown a lot of information at you very quick. And if you need to refresh on some things, that's okay. But we're going to move on to the next step, which is kind of starting to tie this all together. Okay. So to recap, we're going to look at the conduction system of the heart just again, and we're going to remember the first stop is the SA node. Okay. From the SA node, we have a couple superhighways. We're going to loop up and around. And we're going to go to the AV node. From there, it's going to loop, and it's going to go to the bundle of His. And then from there, it goes to our bundle branches. So we got our left bundle branch, our right bundle branch, and then that's going to go up to our Purkinje fibers. Purkinje fibers. All right. So now let's draw this up with some arrows. Okay. Because remember, we're talking about the EKG, we're talking about that wave of depolarization, but we're talking about a vector. And we're talking about the sum of everything. So even though the signal is going out in all directions here, right? From say no, we got signals going this way, and we got them going this way, as all these cells depolarize. The sum of all of that, okay, because the majority of that is going along these superhighways to the AV node. If we were to take every single signal there, the sum, and make it one arrow, it's going to point like this, okay? Because it's going to the AV node. From the AV node, nothing really happens. From there, we go to the bundle of His, which is going to cross, and it's going to go like this, right? And then we got the bundle branches. Because the left bundle branch and the left ventricle is so much bigger, if we were to add the sum of both of these bundle branches, we get an arrow that would look like this. Okay? And then we see the Purkinje fibers are going off in these directions. They finish that. And it's going kind of like. And now that we have these arrows drawn up, hopefully things can make a little bit more sense. And we can add in an electrode. So for the sake of this, we're going to keep it simple. And we're just going to add in lead 1. So if you remember, lead 1 had a negative on the right arm, a positive on the left arm. We're just going to draw just a little 1 here. And we're going to draw this over to the side. Okay, so we're just going, again, just along this x-plane, up and along here. So if we were to take all of these lines down and draw them down, this is where we're going to get our EKG. So lead 1, we're going to start off with nothing. Okay, because the heart hasn't depolarized yet, nothing's going on. Next thing that's going to happen is the SA node is going to fire off. Okay, then we get that wave of depolarization as those cells send the signal to the AV node. So we see this arrow here is moving to the positive. Okay, so we get a little bit of an upwards deflection. Because there's not as much electrical activity going on here, because it is just the atria, we get a little bump. Okay. From there, it's going to go to the AV node, and nothing happens. The AV node is going to hang on to that signal for a minute, let us have our atrial kick, and then it's going to pass it to the bundle of His. So we see this line here is actually kind of going, even though it's down, if we were to draw this way, we have a line like that, nothing, a little bit like that as we go to the bundle of His. And since that's going away from the positive, I should get a little bit of a negative deflection here, right? And then we go to the bundle branches. We have this big arrow. We got that big depolarization of the ventricles going on. And that's going to be a huge upwards deflection because that's going towards that positive. Okay. From there we go to the Purkinje fibers, which in this case we see it's another arrow going to the left. If we were to draw this all out, you see it's going like that. So that means we have a little bit of a negative deflection here. And then we have nothing. Okay? And then what's going to happen is these cells are all going to repolarize. They're going to get ready for the next one. And we're going to get a hump. Congratulations, you've drawn out your first EKG. So looking at each one of these steps, okay, normally this is the part where they start in nursing school and they're like, here is this part of the wave, this part of the wave, this part of the wave, and that's what it equates to. Now you can see what's actually going on here. Okay, we can see why this part here is equating to the SA node in the atria going off. We can see why this part here is our bundle branches and the ventricles going off, and this big hump is the repolarization. Okay, and this winds up applying the same no matter how many ways we wind up drawing this. So let's say we add in that y. Okay, so again, we're going to make this simple. We're going to treat this one as a negative up here, and we'll put a positive down here. And we're going to add in one more lead, draw this out again. So this is going to be augmented vector of the foot, just because it's a straight up and down. Like I said, it's a bit easier to understand. And we're going to do the same thing of drawing this the whole way through. So nothing happened initially. Okay, so we're doing the same time here, and then as soon as the SA node here goes off, we can see it's going down. It's going towards the positive. So since we're going towards positive, we get a little hump. Then nothing happens at the AV node. It comes this way, which is actually down for AVF. So we get a little bit of a positive. And then we have the big boom, right? The ventricles go off. So we get huge deflection there. And then it's going this way. So in this case, it's going to the negative because it's going up. So we get our negative. And then it's going to balance out, and everything's going to repolarize. Now we have lead 1 and lead EVF that we have drawn out. Okay, and this is, you can do this in the exact opposite way. We could sit here in a moment, we're going to go using the leads and figuring out what does that equate to as far as a conduction system. And this is why the EKG is useful, because once you understand how these leads are picking up on this, you can finally understand what's going on with the conduction system of the heart and start diagnosing those issues and figuring out a bit more what's going on. So the next important thing that you obviously need to know whenever you're talking about an EKG is identifying the different parts of the EKG wave. Okay, and the nomenclature here is pretty simple. If you just remember PQRST. Okay, so we'll draw this out. Remember, we had nothing. Then we had our first deflection, which was kind of a hump, and then nothing. So this first one here, okay, the very first hump, this little hump, that's goes to our atrial depolarization. This is the P, okay, or the P wave. Then we have our break. Now, sometimes we can have a downwards deflection here. Sometimes it might not be there. Same, we might have this big deflection, or it might be down. Okay. So we're going to go and draw this. So the first downward deflection, okay, first downward deflection is going to be the Q. Any upwards deflection is going to be R, and any subsequent downwards are S. Okay, this will make more sense in a second as we draw these out a bit more. Finally, you'd have the T wave, which is going to be the big hump that comes after your QRS. And then sometimes you can have a U wave. We're not going to cover that in this video. And that'll just be any kind of subsequent wave up over here. It usually be a bit smaller. Okay. So when we talk about the QRS portion is where nomenclature can get kind of wonky. Just as we saw with the AVF and lead 1, we can have different QRS shapes, right? So it might be flat, and then we could have just totally up and then down like this, right? Or we might look at it and see something that looks like this, right? Or you might look at it and see something like this. So are these all QRSs? Technically, yes, for simplicity. However, each of these are different in their own right. Okay, I'm going to draw another one up over here just for the example. And the way they're actually called, there is a way to talk about the actual nomenclature to them. We're going to cover that kind of briefly just because I think it's kind of cool, right? And it helps make things a bit more sense. So what we had, the first downward reflection here is a Q. We're going to start with this top right one. We see there's no downward reflection. So there's no Q. But we do have an upward reflection, which is R. And then because we don't go below, okay, we don't go below this initial line, we don't have a Q. But we do have another R. Okay, so if we have any subsequent R's or S's, it's called a R prime. So this would be an R prime. And technically, whichever one is the biggest, okay, the biggest hump that we get is going to be one that's capitalized. Any other ones are lowercase. This would be a lowercase r prime. So if you were to see r prime written like this on some paperwork for some reason, this is the kind of wave that they're talking about. Now let's try this one at the bottom. You see we have the initial really big R, okay, and if we look at the other one, we're just going to say this one is the bigger of the two, so it gets the capital. And then we have our downward reflection, which is coming after the R, okay. So this is going to be an S, and it's going to be a lowercase s. So if we were to draw that out, it would be like this, okay. So the Q will only happen before the R, okay. So we're not going to have an RQ, it's just going to be an RS. Okay, so for this next one over here to the right, we have an initial upwards deflection. We can see this bottom part is bigger, so we're going to do lowercase r. Then we have an S, and that's the bigger portion. And we have another R because it's coming back up. So it's R prime. And then if we were to write this out, R, S, R prime. Okay, now we go back over here to the far left. We have that first downward deflection that's going on. So in this case, we have a Q. Okay, that's the Q wave. This here doesn't go above this center line. So we have what's coming up is an S, and this would be a QS. Technically, these are all QRSs. Okay. Uh, Whenever you're doing measurements or anything, you're going to use whatever the largest one is as the R wave. So if we're talking measuring an R to R, okay, you're going to use the R in this case. In this case, you would use the S. So it would be technically an S to S. And this is where just things have not really made sense with how they're equated. Just like you'll hear a QT interval, and the QT, even though the QT interval is starting here, there is no Q in that wave. So some things there can get kind of confusing, but understand that all of these are technically like a QRS complex or the ventricular complex. So the next thing is we start getting into more advanced stuff is understanding the different measurements that are in there as well, as we just briefly mentioned, like QT intervals or PR measurements, R to Rs. So we're going to draw this out again, and I'm going to add a QRS, a full QRS, for simplicity's sake on this. So the first one, the big one, generally worry about is going to be a PR interval. Whenever you hear interval, interval starts at the beginning of whatever is you're reading. So if you hear PR interval, these are starting at the P. Okay, so going P to R, even though, again, it's confusing, it's starting at the Q, not the R. So this here, this measurement from the start of the P to the start of our QRS is our PR interval. I'm going to do this as PRI. Then the next one we'll have, it's another really important one, is the QT interval. Okay, because we're hearing interval, it's starting at the beginning, so the beginning of the Q, and then the QT interval is going to the end of the T. Honestly, doesn't make sense to me either, but it's fine. You can always have a reference card for this. You'll get the hang of it eventually. So going from there to there, and that is our QT interval. So the PR interval is important because it's saying how long does it take from the SA node firing, okay, and it's going to use those superhighways to get to the AV node, and then how long is that AV node hanging on to that signal? Because this bump, okay, if we remember right, is happening at the same time the signal is being sent. Even though this area here is technically the measurement of our AV node hanging on to that signal, it actually starts somewhere up and around here. So we use the PR interval for various medications that are PR prolonging, such as like our beta blockers, or if we're trying to see if the AV node is actually working correctly, right? So let's say the AV node is hanging onto a signal too long, right? There's AV nodal dysfunction. In that case, the PR interval is going to be longer. It's going to be something like out here. All right. So that's why also knowing these normal numbers for these are going to be really, really important. So I'm just going to list off the ones I think are kind of the most important with these. You can get really in depth. There's the PR segment, that is this portion in here. So whenever you hear segment, it's going to the end, right? So we got the PR segment would be in here. We don't care about that, not for the sake of this video. There's also like the ST segment, right? So we're going from the end of the S, and we're going to the T. We don't care about those numbers, honestly, for the sake of this video. Not saying we don't actually care about them. They do have importance, uh, but for the sake of nurses, techs, and again this video, we're not going to worry about those. The ones I will cover, though, I think are really important to remember. The first one is that PR interval, PRI, okay, the QT interval, okay, and then our QRS. I'm going to draw this up here. So the PR interval, this time here, is going to be 0.12 to 0.20 seconds. You may also see the 0.12 to 0.2 seconds drawn out as 120 to 200 milliseconds. These are both right, it's just different ways of writing it out. If you see a 12-lead EKG, they're usually going to be written like this. Our QT interval, okay, is going to be 0.36 to 0.40. And this might change from hospital to hospital. Okay, there might be like a plus minus of 2. Some places might do 0.38 to 0.42. These are just general numbers for you to go by. Okay, and this might go 360 to 400 milliseconds. And then our QRS is be 0.08 to 0.12, or 80 to 120 milliseconds. Okay, so these are the 3 important numbers to remember. Just for general interpretation and everything, because if any of these numbers are off, then we have some kind of really big issue going on. Okay, they're also, if you notice, they're all factors of 0.4 or 0.04, sorry, and that's how the little boxes on the EKG are read. So each one is 0.04 per box. So if you look at a QRS that is 2 boxes wide, we're good. If you look at a QRS that's more than 3 small boxes wide, we're not good. We have an issue or dysfunction at that level of the conduction system. So the thing to understand is narrow QRS versus a wide QRS, right? So what's going on with that? Because we have this normal one that say like this, and we'll say that this is 0.10 seconds versus this guy here, right? And we'll say that this one is 0.16 seconds. So this is wide. This is wide QRS. It's outside that normal that we talked about. So what is going on that's causing that? And how do we know where this kind of signal is coming from? Because we would say this is ventricular. Some people would immediately call this like a PVC. So how do we know that that's what's going on? So if you remember correctly, whenever our heart is getting those signals from the bundle branches, right? They both come down like this, and then they loop up. They should be going at the same time, right? Because we want both of those to polarize at the same time. If one of these is broken, okay, let's say it gets here and it stops, and this one continues, right? Remember, the cells are excitatory, right? So this signal is going to go and it's going to propagate out through the ventricle. But what it's going to do is it's going to have to wrap around the heart, right, to send that signal to get the whole rest of this depolarized. Okay. So whenever we have that wide QRS, it's because the signal is wrapping around the ventricle. It's not contracting both of these at the same time, right? It's contracting one and then the other. So rather than 0.1 milliseconds or 0.1 seconds, sorry, to depolarize both of them because it's going to take twice as long, it might be 0.2 seconds, right? Or in this case, 0.16. So what's happening in this case, with this one over here, is exactly this, right? Is we have their bundle branches that come down and loop up and around. They're supposed to send the signal that way. But this right one is sending it just fine. The left one at some point is blocked. Okay, maybe the tissue here has died. Uh, maybe it's just some kind of abnormality, maybe like congenital. But for whatever reason, the signal doesn't go through the left bundle branch. So what happens is the right bundle branch has to take over, and then it needs to loop back over and depolarize the left. Okay, so because the left bundle is blocked, you'll hear this called a left bundle branch block, right? Just as you may also just see like a normal rhythm, right? It's going ba 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 ba, and then all of a sudden you get this weird big one like that, right? Now, because this is happening before the next beat, it's premature or ectopic, right? It's coming from the ventricles because you see it's wide. This is a premature ventricular complex. You hear this called a whole bunch of different things. They all boil down to the same thing. The ventricles are contracting before they're supposed to. Okay. You might hear premature ventricular contraction, premature ventricular complex. Uh, Both of those mean the same thing. Okay, we're talking about the same thing. This went off before it was supposed to. Now with the left bundle branch block, we can also have a right bundle branch block. Right. So this would look instead something like this, and we'll see a little bit of a slur, and then it'll come up. My favorite place to look at this, even though technically you're supposed to use V1 and V6, I like lead 1, especially when we're doing telemetry. It's not the true way to diagnose left bundle branch and right bundle branch, but they do look like this typically. Okay, so if you have these bunny ears like this and this weird wide one, it's a left bundle. If you have this slurring, because the left was able to go just fine, and then it just takes a little while to loop up and around the right. So whereas this one, most of the contraction is having to happen on this side as it loops up and around. Most contraction is happening on the left side initially. Okay, so it's going here like normal. Here it's getting blocked. So most of the contraction happens, and then it kind of slowly makes its way up through here. That's where we get this kind of slur. Okay, so a slurred S wave. So right bundle branch block. The true way to do this is looking at V1 and V6, the precordial leads, and wherever you see the notches, right, is where it is. So if it happens on V1, this is a right bundle branch block. If you see the notching on V6, right, then it's a left. Okay, so wide QRS means that for whatever reason the ventricles aren't depolarizing correctly. This can be due to a block, or it could just be due to the ectopic focus starting somewhere in the ventricle. Okay, so if it just starts here, it again has to work its way up and around and everywhere. That's where we get something like this. So we talked about before we started to get it into our QRS complexes and how they have different morphologies at each spot. We talked about how 1 and AVF were really useful for determining axis, but also because they're perpendicular, they can readily be used for a couple different applications. So, common one here is figuring out what's called our cardiac axis. In particular, the one that we care about is the ventricular axis. And that's where we're going to look at our QRS morphology for leads. I use 1 in AVF. And that's going to tell us what direction the general signal is going. Okay, so typically, both of these, we're not going to draw P waves or anything on this. We're just going to do mostly upwards deflection on 1, and there should be a mostly upwards deflection on AVF. Okay, this means if we draw from our AV node, okay, 1, just remember 1 has a positive over here, and the negative over here for lead 1, and AVF is negative and positive, right? This means that we're going towards the positive mostly, so we're going somewhere in this direction, right? So it's somewhere this way going that way. And then AVF is also positive, which means that the signal, okay, is going somewhere into this quadrant. All right. So what we're doing in this one, we're talking about cardiac axis and why it matters, is we're breaking up the heart into 4 quadrants. So what we're going to do is just break it up this way, 4 quadrants. And as we know, for normal conduction, once it gets to the ventricles, because the left ventricle is bigger, most of that should be going this way, right? So we should be in this quadrant here. So this is a normal axis, okay? If we're going outside of this, there is an issue. So in the case of this, we're going to break these down each time. So we'll do 1 and AVF again over here. Let's say 1 is mostly negative, right? We got a little upwards there. And we'll do AVF is positive. It's kind of like that, right? So then that means that 1, if we're looking at the negative, right, it's going away from the positive. So it's going somewhere this way. And AVF is positive, so it's coming this way, right? So it's somewhere in this quadrant. If we're in this quadrant, this is right axis deviation. Right axis deviation. Okay, so that means is that for whatever reason, the right ventricle generally is getting more conduction. Maybe it's larger, maybe there's cardiomyopathy going on, or there's right-sided heart strain. Okay, in case such as COPD, where it has to pump harder against the pressure caused in the lungs, or col pulmonale, where you have that right-sided heart failure, same thing. So we're going to have that shift. You see, our 1 is no longer positive, the 1 is negative, and that is shift our axis to the right. But now let's say we take that away and we do this again. Okay, so we'll make AVF this time is going to be negative, and 1 will be mostly positive, right? So again, whichever way is the majority of our QRS in this case, because we have an RS, okay? We have an RS wave here, and then we just have a Q here. So we're going whichever way is mostly positive to figure this out. So 1 is mostly positive, so we're going somewhere in this direction, right? And then AVF is negative, which means we're going away from the positive, which means we're going up. So we translate that to go this way. If we're going this way, it's shifted to the left. We have left axis deviation. This can happen due to something such as hypertension, again, your cardiomyopathy, left-sided congestive heart failure. Same reasons. Generally, it can be a sign of left-sided overload. Now, as I think really the more important of these when it comes to nursing and techs and when we're doing 12-lead interpretation is what if both of these are negative, right? What if this is a big negative and this is a big negative? So that means we're going from the AV node, right? So we're going negative, so this way, and negative, so this way. So they're both going away from the positives. It means that somewhere up in this quadrant. So while our electrical conduction system can bring it this way, it can bring it out here, or like so, or like so. there's no way for it to go this way and then come up, right? So in order for it to go this way, which is called extreme axis deviation, it has to be ventricular. The only way that this can happen is if it's coming from, say, like the apex like this, or it's coming up over here that way. Regardless, it means that this is a ventricular rhythm, and this is one of the ways of differentiating your supraventricular tachycardias from ventricular tachycardias. Extreme axis deviation, something is wrong. Either your leads are on there long, or your patient is about to have a very bad day. So the question comes, how do we use this readily in practice, or how do you readily identify what's going on here? And I like to use what's called the thumb method. Okay, so remember we have lead 1 and AVF. So in normal deviation, right, there's no deviation, no axis deviation. Both of them should be up. So our lead 1 is going to go to the left thumb. AVF is going to go to our right thumb. So all we do is whichever one is up or down is what we do with that thumb. In this case, 1 is mostly up, we bring up our left thumb. AVF is mostly up, we bring up the right thumb. We got 2 thumbs up, we're doing good. Okay. Now if we had this one here, right, we see that 1, so our left thumb is going to be down, AVF is up, so our right thumb is up, so we have right axis deviation, okay, because the right thumb is up. Let's do this again. So let's say 1 is up this time, AVF is down. In this case, our left thumb is going to be up, the right thumb is pointed down. We have left axis deviation. And then finally, they're both down. We're having a very bad day. It's a no-go. Both thumbs down. Bad. Extreme axis deviation.